It's an absolute pleasure to be back with you again, wherever in the world you are. And we invite you to be a part of this session with Dr. Vanita Arora and Dr. Valay Parikh. Dr. Valay Parikh will be our speaker from Staten Island in New York, where he's the director of research, and Dr. Vanita Arora from Delhi. She heads the Apollo Hospital's Electrophysiology program. Over to you, Dr. Vanita. Dr. Valay, take us through leadless pacing and why you consider it an important tool to have in your armamentarium.
Thank you, Deepak. Thank you for having me here. It's a pleasure to be here with the World Society of Arrhythmias. I've been an active part of it. I really miss the meetings and miss everybody on the board. My hello to you all. So today's seminar is very important about the leadless pacemaker, which over the last 10 years, in fact, 2026 is the 10th year of leadless pacemaker that we are celebrating. The first implant was done clinically done in 2016. So this therapy has come as a solace for many group of patients. And I'm so glad Dr. Valaya is going to share his experience with us all. So without wasting more time, I would request Dr. Valaya to take over. And please, the chat box is open. So if you have any questions, kindly put the questions there. We'll try to answer as much as possible. And of course, at the end of the presentation with Dr. Valaya, we'll have a discussion, of course, there. So over to you, Dr. Valaya.
Hi, hello everyone. My name is Valay Parikh. I'm one of the electrophysiologists in Staten Island, New York. I'm trying to share my slides. I promise I'm a better EP than this. Can you guys see my slides?
Yes,
Okay.
they are visible.
Okay. So hello all. So today my topic is leadless pacing, present and future direction. I just want to minimize few things in my screen so I can see my slides. So today my topic is leadless pacing, present and future direction. And before we jump to this thing, I want to thank you, Dr. Arora, Dr. Padmanabhan, Dr. Otto, and faculty of World Society of Arrhythmias for giving me this opportunity to present my views on leadless pacing, present and future direction. These are my disclosures. I'm going to start with this case, which we see on everyday basis. This is hypothetical cases, but we see this every day. A 75-year-old female with normal EF who presents with complete heart block. And the question comes that which kind of device would you implant? Would you implant with a traditional dual chamber pacemaker? Would you go for conduction system pacemaker? Or would you choose one of the leadless pacemakers? With that in mind, there are millions of people who have been treated with pacemaker in last 50 years. First 40 years were primarily because of transvenous pacemaker. However, in last 10 years, we have more options. We have leadless pacemaker, three types of different type of leadless pacemakers in our toolbox, which adds to choices we can have in today's world. The first pacemaker in 1958, when it was invented, it was an external battery pack. And now we have come to the leadless pacemaker, which is size of a paper clip, which makes choices for our patients as well as for us somewhat interesting, but a lot of time difficult. And I hope at the end of the talk, I will make your life more difficult to make those choices. So we also know that although the transvenous pacemaker has been there in the world for past 50 years, but there are problems with transvenous pacemaker, which includes venous occlusions, connector issues, mechanical failure, infections, and more importantly, tricuspid mobility issues. Despite of all the evolutions happen over time, the leads remain the weakest part of our pacing system. Often lead management is required, and it can lead to complex lead extraction, which has its own problems and complications. Transvenous pacemaker complications, depending upon which series you see, it ranges between 7 to 12%. And some of the short-term complications, such as pocket hematoma, pneumothorax, cardiac tamponade, and lead dislodgement, has improved, especially in higher volume centers. However, certain long-term complications, such as endocarditis, pocket infection, lead infection, remains out of control of most of the operators' hands, and it can lead to different consequences after many years, which is unrelated to implant techniques. This led to the concept of leadless pacemaker. The first thought of leadless pacemaker was uh, coined in 1970, where where a nuclear powered pacemaker was thought to be replacing transvenous pacemaker. Fortunately, this did not came into the real market. However, this led to idea of current leadless pacemaker series. And starting 2013, we have three different iteration of leadless pacemaker. The one on the left lower corner, which is the original leadless pacemaker, it was nanostem. And then thereafter, we have two different iteration of leadless pacemaker in the form of Micra AV and Micra VR, which is on the top left corner, as well as recently dual chamber leadless pacemaker by Abbott called Avier on the top right corner. Currently, we have two iteration available in most of the market in the form of Micra AV or Micra VR, which is the Micra series made by Medtronic on the left upper corner, as well as Abbott Avier, which is the dual chamber leadless pacemaker on the right upper corner. NanoStem was discontinued in 2016 because of battery issue, and then it led to battery changes, and it led to the newer version of NanoStem called Avier on the right upper corner. With saying that, I think I'll jump to current generation of devices. My first part of the talk from here on will be talking basics about these leadless pacemakers, and then most of my time will be focused on implantation technique. So Micra series has two distinct pacemaker system. One is called Micra AR and other one is called Micra AV. Essentially, structurally, they are both the same devices. However, there are some software changes in both these devices, making it different devices. The both devices, they are size of a paper clip. They are attached to heart by four nitinol tines. The tines are strong enough to maintain their place during any cardiac contraction, as well as tachyarrhythmias, and reasonably force applied with an external pacemaker or ablation catheters. The battery longevity of this tiny device is thought to be between 8 to 15 years. However, recent studies have shown that it can last up to 15 to 20 years. They're both MRI compatible. As I said before, the both devices are structurally same, but there are software changes making it different devices. Both at this moment are single chamber leadless pacemaker, which is implanted in right ventricle. However, Micra AV has additional feature where it can mechanically sense atrial contraction, causing delivering ventricular stimuli and generating atrioventricular synchrony. If you look at this slide in AV synchrony, in the top part, which is shown as electrocardiogram, single strip electrocardiogram, AM, which is atrial mechanical contraction, is sensed by Micra AV device, and the ventricular stimuli is delivered. And this way, they both maintain synchrony, reaching synchrony up to 80 to 90%. However, true synchrony is achieved by atrial dual chamber pacemaker, which received FDA approval a couple of years back. This device is iteration of nanostem devices, which is fixated with a distal helix unlike micra, which is time-based fixation. The fixation depth is about 1.6 millimeter, which is similar or slightly less than traditional transvenous leads. Although the both devices look very similar, they have a distinct changes in both of them. The HL device has a tiny helix at the top, which gives a better contact with atrial tissue, uh, achieving better electrical parameters, while ventricular devices does not need that kind of device because of structure of RV and wider space available for RV myocardium. Saying that, the benefits of leadless pacemaker has been shown in many studies, and they're mainly based upon minimizing the infection risk either in a pocket or related to lead, as well as all the related complication rates related to lead and related restrictions of tricuspid valve. In addition to that, there is less hardware in the body, and it reduces the procedure time, and it can lead to faster recovery. Saying that, there are certain disadvantages of leadless pacemaker in form of possibility of device dislodgement, pericardial effusion, then certain implantation difficulties, and they are not able to, at this moment, they are not able to perform conduction system pacing, and it can potentially lead to pacing-induced cardiomyopathy. And then there are certain concerns about battery longevity. There's not long inavailability of long-term data, and the biggest concern at this moment in everyone's mind is the cost of the device. We will go over some of this concerns, and hopefully I'll be able to convince that leadless pacemaker is an excellent tool for our patients. So first, looking at the outcome, the MICRA outcome, there's a worldwide registry for MICRA post-approval registry, which includes about 1,800 patients, and it showed the excellent implant success at the end of 2 years with the implant success rate of 99%. Not just implant successes was great, but there was a there was a trend of improvement in reducing the complications related to pacemaker implant as well as pacemaker complications over time. The pacing parameters also remained stable in this study. Similarly, HLDR study, which compared transvenous pacemakers with a newer dual chamber AVR-DR pacemaker, showed that the risk of complication in short term is less than 1%. Primarily, intra-procedural dislodgement and pericardial effusion were minimal and acceptable in this study. More importantly, it maintained AV synchrony up to 98%, irrespective of posture at the end of 3 months, which is an excellent achievement considering that the two devices are in a separate chamber, not connected to each other with any kind of wiring. Recently, we published our short-term performance of outcome of this AVR device, and our data of 102 patients were very similar. Our complication rate was extremely low while maintaining good eye-to-eye synchrony, as well as the excellent capture and pacing thresholds for both atrial and ventricular device. This is for true synchrony achieved by two devices. However, similar results were also seen in Micra AV, which is a single chamber device, and it had achieved synchrony at up to 87% in a real life study in up to 3 months. Now, comparing leadless to transvenous comparison, there were two studies which were published recently. One was a Micra AV in Medicaid population. The other one was related to AVR-DR population. And both studies showed that the complication rate was almost half and the reintervention rate was almost 1/3 compared to transvenous devices, making it very suitable and ask us the question that is this the device for the future rather than going for transvenous pacemaker in everyone. So this brings to the point that who do we choose for our leadless pacemakers? And the common paradigm is that leadless pacemaker should be put in if we cannot put transvenous pacemaker. However, there are certain patients where leadless is preferred because of no leads, and which is no upper extremity venous access, or they have a history of Twiddler syndrome or psychiatric illness, or they are high risk of device infection, or they are on hemodialysis. In addition, the amount of hardware we put in inside the heart is very minimal. So in cases where VVI pacemaker is needed, or someone who needs pacing for transient AV block, these devices are an excellent tool uh, rather than putting them under a knife for the transvenous devices. With that, I'm going to move on to implantation techniques. So the implantation technique.
Well,
Yes.
can I pause you for a second there as you transition? So, data seems to suggest that you're pretty safe with leadless. Data seems to suggest that it's at least non-inferior, if not superior. Data seems to suggest that embolization of the device is not a problem. So, where do you think are the Achilles heels of these devices at present?
Deepak, you're absolutely right that all the data so far are suggestive of at least non-inferior, and in some scenarios it is superior. I think the biggest challenge with leadless pacemaker is the cost. And because of the cost and the barrier in our mindset, we are not using them as a primary device. And that leads to less data generation and the proof. So at this moment, majority of our population, when it comes to dual chamber pacemaker, it's conduction system pacing is preferred. So the amount of leadless pacemaker we put in is very minimal, and without data, it is very hard to convince someone that these devices are better. So I think as these devices come into mainstream and people realize the advantages of leadless pacemaker, we'll have more data, and it will generate robust support on leadless pacemaker.
Would you at any
I
point
just
of
want
time,
to
sorry, go ahead, man.
go ahead.
Would you at any point of time consider it an important study to be done where you're looking at typical dual chamber pacemakers with conduction system pacing versus leadless pacemakers, or do you consider them to be mutually complementary?
My bias is towards leadless pacemaker, and because I have personally seen the leadless pacemaker work very good in short term. In addition to that, I do a lot of complex lead extraction. So I have seen horrible cases. But saying that these are anecdotal evidence, I think the study where leadless pacemakers are compared head to head with conduction system pacing is very important. Um, there are some challenges. First challenge is the biggest challenge is that you will need a large sample to conduct some studies such as this, and it will be very hard to financially justify at this moment to do such kind of study. The second challenge I see is that the techniques in both arm conduction system pacing as well as leadless pacing is not refined yet. We're still learning about both the devices. Although the conduction system pacing has come a long way, there are still variations in techniques as well as the parameters we judge to identify that if it's truly left bundle pacing or some other kind of pacing. So it is going to be hard, but I think over time we will generate enough data to justify that a randomized control trial will be beneficial.
Cool.
I just wanted to add a couple of things here. To the first question, Deepak, which you asked about the data, which is very promising from leadless pacemaker. What I would say is the challenge that we have, because as of today, is that it requires a good training prior to implanting it in a human being. Because traditional transvenous spacing we have been doing for years, and we have learned it in a certain way. Leadless pacemaker requires a different mindset, a different kind of a hand skill set, and the proper training prior to starting these cases is very important. Then we can talk about, the complications which can come in, because whether it is dislodgement or pericardial effusion, the data which you showed, Valay, is going to be tackled in a different way in non-trained hands and in trained hands, because the trained hands would try to not have these kind of complications at all, while untrained hands, in case they have a complication like pericardial effusion, you need to know that then the patient has to go for surgery directly. There is nothing short of that with this. And how to have the dislodgement handled, it is a total different mindset. Having said that, it is not that we don't have dislodgements in the pacemakers, transvenous pacemaker, or we don't have complications like pericardial effusion with the transvenous pacemaker. We do have it even today, after having learned them for 50 years, more than 50 years. We still have those. But here, the learning curve in a different way is very important. That's what one thing which I have learned, which is a challenge, because this is required. And to the second question, which Deepak said, I just want to add that I think we should wait for another year or so, because we are having a new prototype coming up. It is under design. We had some early data in HRS 2025 presented by Devi Nair, that about the prototype which is being created for conduction system pacing. So I think let's wait. Let's not compare oranges to apples. Let's have two kind of oranges or two kind of apples, and then compare them and have a study to say that, then we can actually have the real data, which CSP is better, rather than whether RV pacing versus CSP. There we know the answer, of course, Deepak, right?
I
That's
think,
a matter.
Dr. Arora, you brought up a very interesting point. And you are absolutely right that the techniques and everything about leadless pacemaker is completely different than what we have learned in transvenous pacemaker. We utilize some of the features of transvenous pacemaker, but it's a completely different procedure.
Absolutely.
And the most important part is to have a backup plan. What if things go wrong? What is your plan? And in our lab, we have actually defined protocol for any kind of emergencies, such as dislodgement or pericardial fusion, where I need CT surgery support. And it's automatically done. So when there is an effusion, I just have to say what effusion, and people know what exactly they have to do. They know who to call, they need what supply to bring. And I think having those protocol predefined and accessible to all your team members is essential. Sometimes even doing a dry run, before doing the procedure, that what if there is a dislodgement, what are you going to do? Okay, so let's go over let's do a demo run and see if we can do it in real time more efficiently. And we have come to that way that if there is a dislodgement, which is rare, but if it happens, my staff know exactly who to call. And many times they are even called even before being asked to me. I'm like, they're just called.
Yeah.
Nice.
Right. That's it.
Yeah.
If you're not prepared, you're prepared to lose the war. That kind of a
Yeah.
situation.
Yeah.
Yeah,
Cool.
absolutely.
Yeah.
Let's go ahead,
I,
Valay.
yeah, I don't have a slide about pericardial effusion in particular, but my experience over time has changed. So with original micro device, which was the original leadless pacemaker I have started implanting, the perforations which I have seen in my lab and as well as I've heard other people was had a bigger hole because of the cup of the device. And if I can go back to slide, I just want to show it to the audience. The cup of the cup of the sheath, not the device itself, that was resulting into into an effusion. So even though the size of the cup is very small, the sharpness of the sheath resulted into a bigger tear, and that led to effusion. And many times, a operator did not identify in real time, and they kept on doing the procedure, and they made another hole at the other place, and now you have multiple holes, and the holes were different. Now, saying that, the newer devices, including micro devices, the cuffs are softer, as well as the helix of your devices, they are very tiny. So the holes are very smaller. So most of the time, even if you have a pericardial effusion, a percutaneous pericardiocentesis is enough. And many times you don't need to open heart surgery. But it's always good to have a CT surgery backup just in case.
Of course. Of course.
Okay. So we'll go back to our implantation technique. And I think this is the most important part of our talk. Um, and hopefully I'll be able to convince that it's not as dangerous as people think in their mind if they haven't done any. So, and the first part is access. And I think a large bore access with a femoral vein is it needs to be done. So ultrasound use is highly recommended because you don't want to injure arterial access during this process. And once the access is achieved, serial dilatation is done just like any other large bore access, and a large 26 bore sheath is put in. Before we put large bore access, long wire should be put in up to the right atrium to ensure that there is no difficulty reaching to right atrium. And once that is done, in the closure, when at the time of removal, can be done with a figure of 8 stitch, or you can have a perclose suture placed in beforehand ready. So when at the end of the sheath removal, you can close with a perclose, and early ambulation can be achieved. This is the most important slide for implant location. Majority of complications related to pericardial effusion happen with RV implant. This slide, in theory, explains to us where we need to go and where we need to put and what are our danger areas. So if you look at the left slide, in RAO view, RV body is divided into 9 parts, with apex, anterior groove, and inferior groove at the location where you absolutely need to avoid. Because of the size of atrial and micra, and as well as the Avere device is different, the implantation locations differ slightly. However, for both devices, the devices needs to be placed on a septum and avoiding the free wall and lateral wall. So in RAO view, the ideal location, which is marked in green, number 2, will be ideal location for Avere device, while the Micra device will be implanted in number 5 or mid-septal area. But RAO does not give us the septal or lateral location, so that's why LAO is extremely important, which tells us that the device is on septal wall or free wall. If it's on a free wall, it is an absolute no, and we need to readjust the device to move to the septal location. As I show venogram in next few slides, you will understand how to manipulate your catheter to reach to the septal location. This is a appendogram on the right side, which shows that once you do venogram, you can identify anterior groove as well as inferior groove and apex. And this is the target area, which is mid-septum, where you will place micra, or further out in apical septum or lower septum for Avere devices. This is a real life venogram where whole RV will not light up, but you will have an idea where the apex is and when the RV is. So as soon as you cross right ventricle, it is mandatory to have a venogram. Certain operators do venogram even before with the use of a pigtail to identify RV geography and manipulate their catheter based upon that. Once the optimal location is achieved in RAO, we look at LAO to see if we are on septum. And it is highly recommended that LAO should be at a higher angle, about 40 to 45. If you do it at a shallower angle, it may give you a false sense of security that you are on septum while you are on a free wall. So I'm going to present next few slides to identify how we can make sure that we are on septum, not on free wall. So the first thing we want to see in a high degree LAO is the device pointing, if the sheath is pointing towards you, and if the shape of the tip of the sheath is oval or round. If it's round and if it's pointing towards you, like more likely that you are on a free wall. But if it's oval and it's pointing on the sideways, you're more likely to be on a septum. In addition to that, we do venogram and we see the flow of the contrast, how it is flowing. If the contrast is flowing freely, then more likely you are on a free wall, not on a septum. However, if you are on a septum, the flow will be restricted because you are injecting on a septum and it will achieve some kind of shape like a palm. So you will identify that you are on a septum. If RAO and LAO fits this criteria, then I think you are in a safe space to implant on a septum. So putting all together, what we are looking at is direction of the catheter, not pointing towards you, away from slightly on the right side of the operator, so left side of the patient. Shape of the ring, which has to be oval, and the contrast, which is forms a shape. These are the locations where you want to see that you are on septum, and that's where you implant. Similarly, for right atrial appendage, for atrial aware devices, we over the last couple of years, we have identified that certain locations gives a better electrical parameters and stability. If you look at this diagram in RAO, you want to try to achieve base of right atrial appendage, and in LAO, you want to point the device towards the lateral side, achieving stability and better electrical parameters. This is one of the venogram or a pendogram, where in RAO it identifies right atrial appendage, but in LAO it gives you an idea of lateral wall, and this way you can define your target location. You can either use a pigtail or you can use a sheath itself. The atrial aware sheath and ventricular aware sheath has a protective sleeve, and it gives extra option of doing such thing, unlike micro devices where the cup is slightly sharp compared to this protective sheath. Okay. So once the device is implanted, how do you know whether it's stable? And the micro device, they are time-based device. So they are caught in right ventricular myocardium. So when you give a tug, they should stretch. If they are not stretching, that means you are not caught under right RV myocardium, and it can be a free device. So by giving a reasonably robust tug, you can see the tines moving. So in this video, as you can see, because of the tug, the sheath is being pulled towards micra, while the tines, if you look closely, the top one and the lower one moves and gets stretched. That gives us an idea that the micro device is stable and it's ready to be released. I was going to show you another video of a VR device, but in interest of time, we're gonna skip this one. This video is available on YouTube. Sorry, I'm not able to go to the next slide. So once the device is, before the device is released, um, the aware devices has an option to look at electrical parameters and decide if this site is acceptable. So micro device, which is a time-based device, it's placed based upon target location. It does not have any pre-release electrical parameters that needs to be checked, while aware device has an option to check electrical parameters and decide if this location is good enough. So in this example, in pre-fixation EGMs, you can see a nice ST elevation, local ST elevation or injury current, while after the release, you can maintain that ST elevation, and it gives a better electrical parameters over time. Before we release, just like micro device, we can do similar tuck test for aware devices as well. Here we don't have tines, but what we are looking is stability of device when we do a gentle tug and see if the device is freely floating or it's caught in the myocardium. So this is for atrial device. We want to reduce the appendage movement, and that way we can see if the device is stable. Similarly, for ventricular devices, we can see that. In addition, sometimes we do something called a flexion test, and by flexing, we are moving the proximal end of device while looking at the chevron and the distal end to make sure that they are attached to myocardium and stable. This is from femoral axis. Sometimes femoral axis is difficult to achieve or we cannot reach to right atrium. In this scenario, we can achieve jugular axis and do these devices. They are easy to do. They just require a shorter sheath, and be mindful that the device is going to fall onto apex, which is not the ideal location. So you need to have more flexion. Because of straight shot, the force may be a little bit higher, and need to reduce the force, forward force to the sheet to reduce the risk of pericardial effusion. Now we're going to move to the retrieval of these devices. The advantage of this device is that they are easily retrievable. As Dr. Arora pointed out before, it requires a different skill set, but once you have done a couple of retrieval, they are easy to do. In the study by Dr. Newsel in 2025, they studied all the nanostem implanted, and the success rate of these devices were close to 80%. And if you look at the breakdown of these devices, older the devices, they were easy to capture, while where younger devices had difficulty capturing them. And primarily, this happened because of the docking button of the old devices. If the docking button was not accessible, then they were hard to capture and remove. But if the docking button was accessible, they were invariably able to remove these devices without any problem. This is an example of the case we have seen. I was with Dr. Afzal when he did the case, and what they did is they captured the back end of nanostem devices with a goose snare and removed them. Prior to that, they had placed a micro device and it worked fine in this patient. If the device sometimes gets dislodged, it ends up into pulmonary artery, which as an EP sounds dreading, but you just have to go there and snare it and take it out. It sounds challenging, but the challenging part is only to reach there. Once you reach there, because the devices are lodged into pulmonary artery, they are stable devices. They're easy to capture and remove without any consequences. This led to idea of implanting pacemakers, leadless pacemakers, when there is a need for leadless pacemaker or pacing needs for short term. And in this study by Dr. Epstein from our institute, we published of 17 patients where devices were implanted after lead extraction for infection. These patients have active infection, and during our follow-up for about 6 months, there were no problems with leadless pacing as well as the infection reaching out to leadless pacemaker. All these patients did excellent, and their outcomes was very good. This brings to my point of next topic I'm going to talk about is pacing-induced cardiomyopathy. So one of the concern of leadless pacemaker is that what if patient develops pacing-induced cardiomyopathy? Pacing-induced cardiomyopathy defined by LVEF of less than 50% or change in EF of 10%. In this study by Dr. Lee, the outcomes of pacing-induced cardiomyopathy were very similar between transvenous pacemaker and leadless pacemaker. We just have to be mindful that this data included a lot of single chamber devices and a lot of non-conduction system pacing devices. However, in our practice, we have seen pacing-induced cardiomyopathy better than these results. The key identification in this one is that the pacing-induced cardiomyopathy is seen where the pace duration is higher or the pre-implant LVEF is lower. And because of this, there is a higher dysynchrony, and which leads to pacing-induced cardiomyopathy. So this leads to future direction, which is leadless LV implant. And this is called a YCRT device, which is the size of a rice grain, and it's placed directly into LV, either through a transeptal puncture or retroaortic access. And the device is mapped and placed either in a lateral wall or an LV septal wall, achieving synchrony with an existing RV device, which can be either a right ventricular transvenous device or a micro device. At this moment, there is no report for AVIA device, but it's a matter of time that AVIA device can be programmed together with this leadless pacemaker, making it complete leadless system, achieving bi-V pacing. In this study by Dr. Singh, there were 183 patients, and 6 months follow-up was very promising, with reduction of LV and systolic volume as well as diastolic volume, with improvement of LVEF about 20%. Similarly, the recent study by Dr. Knobs also suggested that the subcutaneous ICD can be performed with a leadless pacemaker. This device is made by Boston Scientific, combined technology of leadless pacemaker with sub-Q ICD, and the success in terms of pacing output of the device, communication between these two devices, and the ATP terminations were excellent. The communication between these devices was achieved in 96% of patients in all postures, making it first hurdle of communication achieved. And thereafter, it also showed that it terminated 61% of VT arrhythmias with ATP only. Thinking of that ATP can be delivered by a small, tiny devices, it's an excellent feat. And I think the future is leadless going to be even for ICDs. And the last one in this innovation series was conduction system pacing. This was a 14-patient trial by Dr. Reddy, where he implanted a conduction system pacemaker and the LV septum. All these patients were undergoing leadless pacemaker, and this conduction system LP was successfully implanted in all these 14 patients, achieving great QRS ranging from 103 to 135. At this moment, this was the first in men trial. So these devices were removed, and we don't have data about long-term success, but it sounds very promising that we will have a conduction system pacing with a leadless pacemaker. Saying that, I'm going to move to my next phase, which is how do I choose my type of my pacemaker? And I broadly divided these devices into two sections. One is sinus node dysfunction, and another one is AV block or AV node disease. So in sinus node dysfunction or sinus Brady patients, where atrial pacing is needed, then the choice is either transvenous pacemaker or dual chamber pacemaker. However, if a patient has permanent AFib where atrial devices are not needed, I think single chamber leadless pacemaker is highly recommended over transvenous pacemaker. In patients where access is an issue, such as hemodialysis patients or transvenous access issue or high risk of infection, leadless pacemakers are superior to transvenous pacemakers. In cases where LVEF is down or expected pacing is 40%, at this moment, conduction system pacing appears to be a better choice. However, over time, with more data, we will see if leadless pacemaker are comparable to conduction system pacing. When it comes to AV block, achieving AV synchrony is extremely important. If EF is low and expected pacing is higher, at this moment, the conduction system pacing appears to be better. However, if there is an access issue or there is a high risk of infection where transvenous devices are not desirable, I think leadless pacemaker achieves a great amount of AV synchrony and is a great tool for our patients. So saying that, I want to go over the disadvantages of a leadless pacemaker, which I described before, and let's see where we stand in with the current data. So possibility of device dislodgement and pericardial effusion. The risk in all the studies is shown to be less than 1%. However, techniques matter, and as people implant more and more devices, they are more comfortable with the tools and the complications. They can be managed effectively and without any long-term consequences. The other one is implantation attempts. In my experience of 500 leadless pacemakers, I'm yet to put one tubular device. Most of my devices can be placed through femoral access without any difficulty. So I would openly say that implantation attempts are not that hard. You just have to be resourceful and understand the anatomy to achieve this. The next question is, if it's able to perform conduction system pacing, are we better than conduction system pacing? And trials are ongoing, and we will need more data to make a bigger statement whether they are comparable to conduction system pacing. And same goes for pacing-induced cardiomyopathy. My question to all of you is, are we sure that pacing-induced cardiomyopathy is really truly a big issue? And what are the risks of putting a transvenous device in a patient versus the benefit? We all need to introspect and decide if it's true for our patient. But the other concern was battery longevity. True that NanoStem had a battery recall. Just like all of our recalls and transvenous devices, I think this is an evolving space, and so far we have reached to that level that battery life can be achieved up to 25 years. So I think so far we are so good, and as technology advances, maybe we'll have an option of self-recharging leadless pacemakers. And the last question is lack of long-term data and cost. And I think this is more to come as the industry matures. I think the cost will come down, more competition and more options for our patients, and it will generate more long-term data. So with this, I'm going to leave a thought for you. And the paradigm has been that the leadless pacemaker is implanted if transvenous pacemaker is not desirable or contraindicated. But I want to ask all of you if the paradigm is shifting, and are we there that should we consider transvenous devices only and only if leadless is contraindicated or not desirable? Thank you.
Dr. Valay, that was amazing.
Yeah.
Go ahead, Dr. Vanita. Your thoughts.
Go ahead, Deepak. Yeah.
No,
I'll
no,
wait.
you first.
Wait. Go ahead.
No. So, I mean, this is essentially a tour de force. We understood the challenges. We understood the issues. We understood probably that we need a shift in the way we think about it. And in my opinion, most certainly, that last slide was very important, especially if you have somebody who's not very experienced in transvenous spacing. This session is essentially targeted towards early career electrophysiologists, fellows, and there are a lot of nuances in implanting pacemaker devices, dual chamber pacemaker transvenous devices across a variety of anatomies. Now, whether the patient is justified in having somebody who's not conversant with that variety of anatomy and therefore getting a transvenous pacemaker implanted versus just getting a leadless pacemaker implanted is a question that we probably need to answer. And eventually, you probably need to consider pacing as a life-saving technique. More the number of people who do it, the better it is. And most certainly, leadless pacemaker seems to be a more safer option for dual chamber pacing as compared to transvenous pacing. What are your thoughts on it? A trained electrophysiologist implanting a transvenous versus a newer, just passed out cardiologist implanting a leadless pacemaker.
I think irrespective of devices, the training is very important. And the learning curve appears to be stiffer for leadless pacemaker. And that's primarily just because we haven't been trained properly in this space. I would highly recommend to train into leadless pacemaker because this is the future. Fortunately, in today's world, there are a lot of resources available, a lot of mentors available. Dr. Arora, if you're in India or wherever she can reach you, is one of the great mentor you can have. And there are many mentors and many industry support available for leadless pacemakers. So in today's world, saying that I cannot implant a leadless pacemaker is somewhat questionable. I think it's our responsibility to train ourselves into this new technology. And we know that in EP space, we have come a long way. Think about ablations, think about left atrial appendage closure. Those are new technologies that we have mastered over time with just practice and understanding and learning the nuances. So I think this is the future and people need to be trained. Now, your question is, should anyone do leadless pacemaker? And absolutely not, because it's a completely different device implantation technique. An experienced electrophysiologist should be able to implant a leadless pacemaker without any difficulties. A new cardiologist, means not EP, should probably do transvenous and leadless after going through an extensive training. Saying that, a lot of this it's an individual responsibility. Do you feel comfortable? Do you feel that you're trained fairly enough? And that's where you embark into this journey.
I do agree with you, Valay. The training part is important, and my experience as a mentor or as a proctor shows that the EPs are better at handling the catheters. They know how much not to push, how delicately to handle the device because they are used to using the catheters, you know. The ablation work is again the same, it's again is same sensitive as is the leadless work. So they know how much to force to apply, how much not to apply, where not to push. So they learn much faster than the new cardiologist or the intervention cardiologist, you know, who do not know how to handle, how to do flex or lock the catheter, and how to use both their hands, become ambidextrous basically doing this. So I have found EPs getting trained in this much faster, learning it much faster than other cardiologists. I was just curious, you said most of your implants have been femoral, right? And you have not done any jugular implant. So you have done, in case you have interrupted IVC draining into the hemiazygos and draining into the persistent left SVC, then what do you do? Have you ever come across this kind of an anatomy?
Yeah, fortunately, I haven't. I haven't. But I think jugular access is completely doable. One of my partner has done few cases, and so jugular access is not hard. Actually, it's easier than a femoral access because
I agree. I
going
agree.
to RV is easy.
Yeah,
And the slide which I presented about conduction system pacing, if that materialize, that will have jugular access
jugular, easier.
to fall into LV septum, so RV septum, and achieving the conduction system pacing. So I used to put jugular access for CS catheter, which I don't anymore. But I think
Yeah,
we are learn we have all have that skills, and I think we're going to start using those skills again.
sure, sure. So, Deepak,
Okay. Let me
yeah,
let me spark off some controversy.
okay.
So I have a lot of colleagues who say when you're using the dual chamber leadless pacing, you are also condemning a patient to an extraction procedure at the end of 7 years or 8 years or 14 years, whatever you say, the dual chamber life is going to be. So, is it actually justifiable for a leadless pacemaker benefit versus a good old fashioned dual chamber pacemaker? What's, unless there is a contraindication, why subject someone to the definite risk of a extraction procedure?
Valay,
Even
you want to
this
take that question?
Yes, I will. This is my favorite question, actually. And I'm
Good.
going to continue with this controversy. So, if you remember the case I presented, a hypothetical case, 75-year-old female with complete heart block, normal EF, right? This is an ideal case. And I think that points to your question that what should you do? Should you put transvenous device and leadless views? At this moment, we don't have data, head-to-head comparison, long-term data. But we do have short-term data and data up to 2 years, which clearly shows that the risk of complication is lower with leadless pacemaker over time. And we all know in our practices that that extractions do need to be done after many years, and those has its own higher risk, and those are even higher skilled procedures that it's done at limited centers in throughout the world. So that is one thing to always keep in mind, that am I subjecting this patient for pacemaker for, let's say, 20 years, 30 years, or I'm doing pacemaker just for a couple of years and keeping them alive for next 2 3 years. That's the first and most important question. And when I do cases with my patient, I have an honest discussion with my patients that we don't have a lot of long-term data with the less pacemaker. We do have a lot of long-term data with transvenous pacemakers. So we know what can go wrong with transvenous and what is the track record of transvenous devices. So I think that is first thing to do. There's a second question which you ask is that, oh, what happens if the battery runs out? Well, it did happen in nanostem in real life, where the leadless pacemakers have a battery recall, and majority of pacemakers were extracted successfully without any complication. So that is a possibility. Again, different skill set, but it's not that hard. You just have to put a snare attached to docking button and remove it. Well, when you do first time, or when you hear me speaking like callously, it just sounds like wow, it must be very easy. Sure, it's not an easy, but it's doable, and it's something that we can easily learn. It's not a big steep learning curve for that. The next question you ask me is the battery life. That the battery life is changing. I mean, like imagine we were using gas powered cars, and now we have to EVs, and the EVs are changing. They're expanding the battery capacity. So I think over time the battery life will just improve and improve. Can it happen that batteries go out and we cannot take it out, or we don't want to take it out? Certainly. So the size of my granavir are small, that we can implant up to 2 or 3 leadless pacemakers in RV simultaneously. It hasn't reached to that level because we haven't seen that long-term outcome, but it is theoretically possible. Now, saying that, this is a very this is a very important point, that let's say if you do a leadless pacemaker and after 5 years, 7 years, 8 years, leadless pacemakers are not desirable or not happening. Well, now you can go back to our traditional transvenous pacemaker and you save 5 to 7 years of lead time. As an extractor, I'll be very thankful to you.
Well said.
Yeah. And
Well,
Deepak, in addition to this, I would like to add, uh, you know, you do the programming of your pacemaker, right? Now you are used to doing a set kind of a programming for the transvenous pacemaker. In with the leadless pacemaker, especially with the dual chamber leadless pacemaker coming in, the programming can be done in multiple ways. You have to understand what is the conduction system problem of the patient. If it is totally sick sinus syndrome, you do not need to put it in the dual chamber mode with a long AV delay. You put it in an AAIR with the backup of VVI. Okay, so it is only the pacemaker, one pacemaker working, the other is in a standby mode. If you have an intermittent complete heart block, you can put it in the VVI mode with the standby of AIR. You can put it in the dual chamber mode and have a lower rate around 45, 50, where it is not pacing the atria, it is just pacing the ventricle with the AV synchrony. So all these things, the different kind of eye to eye programming that can be done with aware dual chamber pacemaker actually is to do increase the longevity of the pacemaker devices, so that as far as possible, see whatever aware VR devices I have done. I mean, as many as the cases I have done till now, I have seen the longevity of 20, 21 years. Their projected longevity is 17 years, whatever they have conveyed. But I am coming to that 20, 21 years of longevity I am getting. Atrial pacemakers also similarly, whatever is the projected longevity, I'm getting it much more than that. So I think we have to wait and watch and see. And programming in a right way, of course, is a very important thing to be done. See, here let me tell you one more thing. With aware atrial pacemaker, generally at the time of implant, the threshold is high. It is high. I have left it at even 3 threshold at 1 millisecond, and I've just accepted it because I know by next day or by 48 hours the threshold will come down. If my rest of the readings are good, I have a good P wave, I have a good impedance, and I have a good current of injury, I know it will settle down. And then I, of course, program it according to the threshold that I'm getting, not leaving it at the high output and then forgetting about it, because that compromises the battery.
I agree. I agree. And these points I thought were important to bring out because these are the common reasons why people say we don't want this, especially when there is no economic challenge. So,
Right.
Yeah, I think Dr. Arora, you also brought very interesting point that you can actually upgrade the devices. So one of the misconception is that once you put a leadless pacemaker, you're stuck with it and there's no other future to that. We already have a pure dual chamber leadless pacemaker in market. We also have an FDA approval for a LV leadless pacemaker. Conduction system pacing is happening. So there are many options. In addition to that, you can off label, you can mix and match devices. So let's say if you have a micro device, can you put an atrial device, atrial aware device? Certainly you can, and they will program very fine actually. We have few patients, younger patients, where they had sinus node dysfunction, but at that time they didn't want transvenous pacemaker, had a micro VR, pacemaker syndrome, and now we have put an atrial device and they do fine.
exactly. Exactly. And I think sharing these is where the solution is, sharing these experiences on a more wider platform to take away the fear of, oh, we are stuck with one. Dr. Vanita, you are saying something.
I was saying that different indications you can actually, as the indications are going on, as the technology is advancing, you can have two different devices serving their purpose in the same patient. Because if you have done VR in the past, say micro VR in the past, doesn't mean that if the patient develops sick sinus syndrome today, you cannot pace it with an aware, or
Yeah,
you
yeah.
remove the micro and then put a dual chamber aware. It is all doable. It is all permutation combinations are possible now.
Absolutely.
And with the, I don't know about Valaya, but here, once we are training the people for leadless pacemaker, even on the simulator and everything, the extraction tool, the snare is available. We are also teaching them how to do the extraction in case need be. And the same snare can be used for both Aware as well as Micra. The both the devices, they fit into that same catheter, the once you are docking it in. So I think things are becoming more non-complicated now, and they are taking their turn. So this is the technology I'm looking forward to seeing it more and more in future, of course. Today also, why not? Why future? Today also.
And I mean, in our practice, we have reached to that level that we offer leadless to everyone, irrespective of their health, and we offer leadless to everyone. Very few indications where actually we go for conduction system pacing is where their EF is very low, and they need a high burden of pacing. So and again, I I I don't have a data, but I firmly believe that not everyone needs conduction system pacing. I know conduction system pacing is great when it's achieved, uh, and it's easy to do. It's not that hard to do anymore with the tools and toolboxes and understanding we have. But my question always is that, do I need to subject everyone to conduct transvenous devices? Do I need to subject everyone to have leads in their body for next 30 years? And some of them will have infection over time, and so it's always a question that which patient should be subject to leadless versus transvenous devices.
Hence my
I think as
randomized.
of today, I am more scared of infection rather than LV dysfunction. LV dysfunction, pacing induced LV dysfunction, I still can manage. But infection, it comes so badly to these patients who come with extrusion. I share you a data of one patient. I mean, I gave him a CSP. He came with LV ejection fraction of 40%, left bundle branch block, intermittent complete heart block. He came to me, I gave him a CSP 4 or 5 years ago, and his EF improved beautifully. He came back to normal LV function, and the EF improved to 55%. LV was normal size. Now, out of the blue, after 4 years, with no prior warning, he came with extrusion. He had totally healed. It was beautifully healed. Now I don't know whether it was an allergy that he had, or we couldn't find any bug, no bug in the blood culture, no bug, and it was a sideways extrusion that happened for that device. Now what do I do with that? Okay, now what I told them, I said, okay, I will remove this, everything will go out. I will give you a new device on the right side. They agreed to it, right? And I went ahead and I did a fresh implant on the right side after 48 hours of antibiotics, removal of everything, no culture positive. Can you believe within a month he came with the extrusion of that device? Within a month. Uh, Whether it was the allergy which was happening or what was happening, again, no culture positive. Nothing, no blood culture positive, no fever, nothing at all was there. But he came with the extrusion. So now I have removed everything and I have given him a AV micra because he doesn't need atrial pacing. He needs atrial sensing and ventricular pacing. I've given him his LV function is now normal. I'm keeping my fingers crossed that it should remain okay. If it has improved once, so it has okay. It should be okay now. But this is how things sometimes very tricky things happen, which are beyond us to understand.
Well, if his EF drops, you can always upgrade.
Yeah, that I can do. Yes, of course, I
Yeah.
can do that. Yeah.
Yeah. Anyways, this has been a very, very fun discussion. I would now request Dr. Valay and Dr. Vanita to give me a one-liner to take away. And then I think we can take this discussion offline and continue to have this for times to come. Would that be fine, guys?
Of course, Dr. Parikh.
Go ahead, Dr. Vanita. Why don't
Yeah.
you start?
My one-liner message is, don't fear leadless technology. It is your friend, and I think it's the future, and it will replace transvenous devices very soon.
Yeah, never say no to new technology. Never. It is the future, and I see leadless future.
Perfect.
So that's all.
Perfect. Thank you, guys. Thank you for sparing time on a Saturday morning at your end, Valay, and Saturday evening at your end, Dr. Vanita. I look forward to all our viewers to see them review this video at their leisure if they're not in on this session right now. And thank you very much, the World Society of Arrhythmias and Magnum Opus, for allowing us this opportunity to present and have this lovely discussion with two of the people who are very dear to me. Thank you very much once again. Everybody, have a great rest of the day.
Thank you.
I see Dr. Richard Sutton has, he has signed in. Hello, Dr. Sutton. How are you doing? I just wanted to say hello to him. He's a great friend, a wonderful electrophysiologist and a great friend.
He was one of the moderators on one of our sessions and was very much fun. We had a lot of fun on that session.
He is. He's amazing. He's amazing.
Are you there, Dr. Sutton? Before we sign off, we'd like to hear from you.
Yeah, he's one of the attendees,
Yeah.
I can see that.
No worries. Let's sign off and we can catch him
Okay.
offline. Thank you very much once again, everyone.
Take
Have a
care.
great rest of the day. Bye.
Thank you. Bye.